Welcome to the Deep Dive. Today, we're tackling a really critical topic in ophthalmology, central retinal artery occlusion. You might hear it called CRAO.
That's right. Think of it like a sudden um, plumbing problem in the eye, a blockage that needs dealing with fast.
Okay.
And we're diving into some revision notes today, aiming to give you a clear, sort of high-yield grasp of this ophthalmic emergency.
Right. So the mission is covering all the bases: definition, pauses, risks, what's happening inside the eye.
Exactly. Diagnosis, management, prognosis, potential complications, the whole lot. We want to really help with understanding and, recall.
Makes sense. That idea of sudden vision loss is quite dramatic, isn't it? So understanding it quickly feels vital. Let's get started.
Okay, let's lay the groundwork. So central retinal artery occlusion, CRAO.
Okay.
Basically, it's when the main blood vessel, the artery feeding your retina, suddenly gets blocked.
Okay.
And the consequence is, well, severe vision loss, usually in just one eye.
Yeah.
It's absolutely an ophthalmic emergency.
Right, you mentioned emergency. Time is really of the essence then. What's typically causing this blockage?
Yeah, the most common culprits are thromboembolism. Often that's linked back to atherosclerosis, the hardening and narrowing of arteries due to fatty plaques.
Okay, atherosclerosis.
And the other big one is arteritis, specifically inflammation of the arteries, like temporal arteritis or giant cell arteritis, something we really have to consider, especially in people over 50.
So like a clot traveling or inflammation.
Pretty much. A useful mnemonic might be thinking FA fatty plaques from atherosclerosis and arteritis blocking the artery.
FAT, okay, got it. So a sudden blockage, severe vision loss. What are the key signs clinically that point towards CRAO?
There are two really key features we look for. First, something called a relative afferent pupillary defect, or RAPD.
RAPD, okay, how does that work?
Well, you shine a light in the good eye. Both pupils constrict normally. But when you swing the light to the affected eye, its pupil doesn't constrict as strongly. And sometimes, the pupil in the good eye might even dilate slightly. It shows the signal isn't getting through properly from the affected eye.
Right, the signal's weaker. And the second sign?
That's the one many people remember, the classic cherry red spot seen on a pale retina during fundoscopy, the eye examination.
Ah, yes, the cherry red spot. Why does that happen?
It's quite striking. The retina looks pale because it's starved of oxygen. But the macula, the central part responsible for sharp vision, sometimes has a separate blood supply from the layer underneath the choroid. So it stays red, looking like a cherry against the pale background.
That's a very vivid image, and it really emphasizes the urgency, doesn't it, trying to prevent permanent damage?
Absolutely. And just to circle back, always remember atherosclerosis as a common cause. And definitely consider temporal arteritis in older patients, say over 50.
Got it. So moving on to the etiology, the specific causes, you mentioned thromboembolism is common.
Yes, that's the most frequent reason. A blood clot, an embolus, gets lodged in that central retinal artery and just stops the blood flow.
And where do these emboli usually come from?
Often they originate from the carotid artery in the neck, maybe plaque breaks off there, or they can come from the heart, especially as there are issues like atrial fibrillation or valve problems, or even from those atherosclerotic plaques elsewhere.
Like debris floating downstream and getting stuck.
Exactly. That's a good way to think about it.
Are there less common causes we should be aware of?
Yes, the less frequent. Things like vasculitis, general inflammation of blood vessels can cause it. We mentioned giant cell arteritis already. And also hypercoagulable states where the blood is just more prone to clotting.
Okay. Maybe more VHG, vasculitis, hypercoagulable states, giant cell arteritis.
AHG, yeah. That works for the less common ones.
Okay.
Good one.
So a few potential sources. What about risk factors? Who's more likely to get a CRAO?
Well, several things increase the risk. Older age is a big one. Then, as you'd expect, atherosclerosis itself, hypertension, high blood pressure, diabetes, and hyperlipidemia, which is high cholesterol.
The usual vascular suspects, then.
Pretty much. Plus smoking, having existing cardiovascular disease, maybe a previous heart attack or stroke, and any history of embolic events before. It's really tied into general cardiovascular health.
And maybe AHHD plus smoking and heart disease, age, hypertension, hyperlipidemia, diabetes.
AHHD.
Yeah.
That covers the main modifiable ones plus age. Good way to group them.
Okay, that makes sense given it's a vascular issue. So let's talk pathophysiology. What's actually going on in the eye at that moment?
Fundamentally, you can think of CRAO as an ocular stroke. That blockage leads to ischemia, a severe lack of blood flow, and oxygen reaching the retina.
And the retina is the light-sensing tissue.
Exactly. It's in the back of the eye, and it's incredibly metabolically active, so it really suffers quickly without oxygen.
And just to confirm, the blockage itself is usually caused by...
As we said, typically an embolus, or sometimes it's related to underlying atherosclerotic plaque right there in the retinal artery, or inflammation from vasculitis narrowing the vessel.
And we keep saying it, but the timing is just so crucial here.
Absolutely critical. The retinal damage starts happening fast and becomes irreversible. The window for any potential treatment to restore vision is really narrow, debated, but often quoted around 90 to 100 minutes from the onset. After that,
The chances drop significantly.
dramatically, yes. The direct result is that sudden, often profound vision loss. So key mechanisms: embolism, atherosclerosis, inflammation.
Okay. Now, if someone comes in with sudden vision loss, CRAO is high on the list, but it's not the only possibility, right? What are the differential diagnoses?
Good point. You absolutely need to consider other things. A blockage in a smaller artery branch, that's branch retinal artery occlusion, or BRAO, it usually causes more of a partial field defect.
Okay, BRAO. What else?
Then there are problems with the optic nerve itself. Retinal detachment, where the retina pulls away, acute angle closure glaucoma causing sudden high pressure, or acute optic neuritis, inflammation of the optic nerve.
So quite a few mimics. Maybe BORAG for branch occlusion, optic nerve issues, retinal detachment, acute glaucoma.
BORAG, I like that. Yeah, branch occlusion, optic nerve, retinal detachment, acute glaucoma helps keep them in mind. Careful examination is key to telling them apart.
Definitely. Let's get a feel for how common this is. What's the epidemiology like, say, in the UK?
It's estimated around 1 in 100,000 people per year in the UK. So not super common, but significant.
And who does it typically affect?
It's predominantly seen in older individuals. The incidence really climbs with age. Most patients are over 60. If you see it in a younger person, you really need to think about other underlying causes like maybe valvular heart disease or a clotting disorder.
Any gender difference?
Slightly more common in men than women, but not hugely so. The main association is definitely age.
Okay, so be extra vigilant in older patients with sudden vision loss. Let's dig deeper into the clinical features. How does it typically present?
The absolute hallmark, as we've said, is sudden, painless, and usually severe loss of vision in one eye. Patients might describe it like a curtain falling or a switch being turned off.
Sudden, painless, severe. Got it. And when we look inside the eye...
That's where we see the classic signs on fundoscopy. The pale, ischemic retina and that central cherry red spot at the macula we discussed.
Because the macula might have that separate choroidal supply.
Exactly. The ciliary retinal artery, if it's present, spares the macula, initially making it stand out. You might also see the retinal arteries looking narrowed, attenuated, and the veins can look a bit abnormal too.
Okay, and other signs.
The relative afferent pupillary defect, the RAPD, is usually there. Sometimes you can actually see the little embolus lodged in one of the vessels, though not always.
Wow, you can sometimes see the culprit.
Occasionally, yes. Patients might also mention floaters or specific visual field defects, depending on the exact pattern of occlusion. And while it's typically painless, some might feel mild ocular pain or discomfort.
How bad is the vision loss usually?
It's often very significant. Around 94% of cases have markedly reduced vision, often down to just counting fingers or worse.
That's profound.
It is. And sometimes there's a warning sign. About 10% of people might have had episodes of amaurosis fugax before the main event. That's like a temporary blackout in vision, lasting minutes.
A transient ischemic attack of the eye, essentially.
Kind of, yeah. And while it's nearly always one eye, very rarely, maybe 1–2% of cases, it can be bilateral, though often not equally severe in both eyes.
Okay, so a mnemonic for features. Sudden, painless, severe vision loss, pale retina, cherry red spot, RAPD. Maybe SPP, shriek.
SPPC. Sudden, painless, pale, cherry red spot, RAPD. Yeah, that captures the key ones. A bit blunt, but memorable.
And you mentioned systemic examination is important, too.
Absolutely crucial. You need to listen over the carotids in the neck for bruits, those whooshing sounds that suggest narrowing. Check heart sounds, feel the pulse for irregularity like an AFib, measure blood pressure. It's all part of looking for the underlying cause.
Right. And you briefly mentioned BRAOs earlier.
Yes. Branch retinal arteriolar occlusions, usually caused by smaller emboli lodging further down the arterial tree. They typically cause an altitudinal field defect, like losing the top or bottom half of your vision rather than total central loss.
Got it. So the clinical picture is key. How do we confirm it with investigations?
Well, the diagnosis is often strongly suspected based on those clinical findings alone. but tests help confirm and investigate causes, obviously a formal visual acuity test. Then the detailed fundus examination.
Any imaging.
Fluorescein angiography can be useful. You inject dye into the arm vein, and it shows delayed or absent filling of the retinal arterioles, confirming the blockage. OCT, optical coherence tomography, gives detailed retinal scans and can show swelling in the acute phase or thinning later on, especially helpful if the presentation is delayed.
And looking for the source.
Definitely. A carotid Doppler ultrasound is standard to look for plaques or stenosis in the carotid arteries.
What about blood tests?
Yes, depending on the situation. Basic vascular risk assessment means checking blood pressure, blood glucose for diabetes, and a lipid profile.
Okay.
If you suspect something else, like in a younger patient, or if there are unusual features, you might do a clotting screen, coagulophilia tests, antiphospholipid antibodies, maybe a vasculitis screen.
And for older patients?
Critically, in anyone over, say, 60, or if you suspect giant cell arteritis for any reason, you need urgent inflammatory markers, ESR and CRP. They must be checked immediately. A temporal artery ultrasound might also be done.
Because GCA needs urgent steroid treatment.
Exactly, to prevent vision loss in the other eye, amongst other things. And longer term, everyone needs that cardiovascular risk assessment, including fasting glucose and lipids, think broad categories, vascular risk tests, inflammatory markers, clotting studies.
Okay, so a mix of eye tests and systemic workup. Now the big question, management. What can we actually do?
Yeah, this is the challenging part. Unfortunately, there is no single established treatment that reliably reverses the vision loss from CRAO once it's happened.
That's quite sobering.
It is. So the main immediate focus shifts. It becomes about identifying and treating any underlying systemic cause, like significant carotid stenosis, and aggressively managing all those cardiovascular risk factors we talked about: blood pressure, cholesterol, diabetes, smoking cessation.
And specialist referral is key.
Absolutely essential. Urgent referral to an ophthalmologist.
So, limited options for restoring vision acutely. What treatments are sometimes tried in that very early phase?
Well, acknowledging the generally poor visual prognosis, maybe only a third see some improvement. There are things sometimes attempted, often within hours, though the evidence is weak for most.
Like what?
Things like trying to lower the eye pressure rapidly, maybe with intravenous acetazolamide, or even a procedure called anterior chamber paracentesis, where a tiny amount of fluid is drained from the front of the eye.
Trying to dislodge the clot.
That's the idea behind ocular massage, applying firm intermittent pressure to the eyeball. The hope is it might jiggle the embolus downstream. In very specialized centers, they might attempt intra-arterial thrombolysis, delivering clot-busting drugs directly via a catheter.
But these aren't routine.
No, not routine, and carry risks. Their effectiveness is really debated. If there's a suspicion of concurrent giant cell arteritis causing an anterior ischemic optic neuropathy, AION, then systemic steroids are vital, but that's treating the GCA.
Maybe APM for the acute attempts. Acetazolamide, paracentesis, ocular massage, maybe thrombolysis.
APM, yeah, that covers those unproven acute measures. But the real focus has to be long-term.
Okay, so let's talk long-term management. What's the plan after the acute event?
Long-term is critical because having a CRAO flags you as being at much higher risk for other vascular events, particularly stroke and potentially vascular dementia.
Right, it's a systemic warning sign.
Definitely.
Yeah.
So the goals are find and address the underlying cause, if possible, check for any clotting disorders, and then aggressive secondary prevention. That means managing hypertension, using statins for cholesterol, and usually starting aspirin or another antiplatelet agent.
Standard cardiovascular risk reduction, basically.
Exactly.
Any specific interventions based on findings?
Well, if the carotid Doppler shows significant stenosis, then carotid endarterectomy surgery to clear out the plaque might be recommended to reduce the risk of future emboli causing a stroke or another CRAO.
Okay.
And patients need ongoing eye follow-up with ophthalmology to monitor for complications like neovascularization. They might need referral to low vision services for support and aids.
And driving.
Yes, that's an important point. Depending on the level of vision loss and whether it affects both eyes, patients likely need to inform the DVLA or equivalent driving authority. There are specific visual standards for driving.
Lots to consider long-term. What about the overall prognosis for vision?
As we've hinted, generally poor for significant vision recovery. Some degree of improvement happens in maybe a minority, and spontaneous near-complete recovery is very rare, perhaps 1 to 8% of cases.
So most people are left with substantial vision loss.
Unfortunately, yes. The final outcome depends a lot on how much retinal damage occurred initially and how quickly, if at all, blood flow was restored.
And you mentioned increased mortality risk.
Yes, particularly if visible emboli were seen in the retinal arteries. These patients have roughly a threefold increased mortality risk, mainly from cardiovascular causes. They really need to be managed with the same intensity as someone who's had a heart attack.
That really drives home the systemic connection. Finally, what are the potential complications within the eye itself following a CRAO?
The main one, of course, is permanent, severe vision loss. But beyond that, the eye can develop ocular neovascularization, abnormal new blood vessels growing on the iris or retina in response to the ischemia.
And that's bad because...
Because these vessels are fragile, they can bleed, and crucially, they can block the drainage channels in the eye, leading to a very severe, difficult-to-treat type of glaucoma called neovascular glaucoma. It can be very painful and further damage vision.
So follow-up is needed to catch that early.
Absolutely.
Yeah.
Prompt diagnosis and management of the CRAO itself, while not great for restoring vision, might help reduce the risk of these later complications. Regular ophthalmic checks are vital.
Okay, let's try and summarize our deep dive on CRAO. It's a sudden, serious ophthalmic emergency. Vision loss can be devastating.
That's the crux of it. Early recognition of those symptoms, sudden, painless, severe vision loss, and knowing the risk factors is key.
While treatments to actually reverse the vision loss are very limited.
Right, the real focus has to be on finding and managing the underlying systemic causes, the cardiovascular risk factors, to prevent future events like stroke and monitoring for those eye complications. It's crucial for all healthcare professionals to grasp this.
Definitely.
And it really is a powerful reminder, isn't it? How something happening in the tiny blood vessels of the eye can reflect major issues in the rest of the body's vascular system. That interconnectedness. Maybe the key phrase to remember is, time is vision.
Time is vision. A stark but important message. And if you, listening, want to delve deeper into CRAO or other conditions for your revision,
And PassTheMSRA.com is the place to go for comprehensive, high-yield revision materials.
and for some excellent free resources to supplement your learning, check out freemsra.com.
Great resources there, too.
Thanks for joining us for this deep dive into central retinal artery occlusion.